Good morning, Dr. Tom McNamara, Professor Emeritus from the UCLA School of Medicine, Department of Radiology. It's my pleasure to be part of this wonderful series sponsored by Dr. Walker's group in Louisiana, the NCVH Digital Education Series. So thank you very much, Dr. Walker. I'm going to discuss today the blue toe syndrome. What I think is regarded as unusual cause for blue toe syndrome has, in my own experience, been the usual cause of blue toe syndrome. And that role is of thrombus. So therefore, thrombolysis would actually have a role, which you wouldn't expect to be the case based on the commonest concept of blue toe syndrome. So I'm going to go over diagnostic features, therapies, and results. The etiology is what I think is in question here. And of course, etiology will determine the treatment. As I mentioned, the blue toe syndrome is generally thought to be due to atheromatous particles that have embolized into the digits of the foot. And origin is thought to be from the aorta or the iliac arteries. And the cause is generally precipitated, or I should say the precipitation is usually that it's dislodged, that material is dislodged during catheterization or associated with anticoagulation. The exact mechanism of that is not clear. But it can be a devastating problem because it involves the real terminal vessels, resulting in tissue necrosis. It can actually be a lethal problem. And what is the role of lysis? Usually it's considered to be none because of the etiology being regarded as atheromatous material. This is just an illustration demonstrating very atherosclerotically diseased aorta, and then tiny particles of that material embolizing, generally bilaterally because of it being in the aorta. This would be pictures of the usual appearance. The one in the middle represents atheroma from above the aortic bifurcation, and below the that level, it would be unilateral, which we see on the image on your left at the bottom, and then the right just shows it normal. But if you have a unilateral, as we do in this patient, blue toe, and you can see the appearance is actually not the typical tiny little petechial appearance. It's a bluish discoloration. This is not, in my experience, this is not the typical appearance of atheromatous embolization. Should alert you to the possibility that this actually represents embolized clot. I've had the experience now with 16 cases, more in the last 20 months. I've actually seen 4 of them. They all presented with sudden onset of marked pain and absence of pedal pulses, whereas in the atherosclerotic and atheromatous embolization, they have a pedal pulse because it's tiny particles that have actually embolized beyond our most distally palpated pulse to involve the digital vessels. 9 of them actually also had a history of preceding claudication. Therefore, we would suspect stenosis in the blood vessel supplying that limb. And none of them had arrhythmias, they were not on anticoagulants, and they had not been catheterized. The illustration of what my concept is and what I'll share with you in terms of imaging is that proximally in these patients, there is an atherosclerotic induced stenosis, and that the progression of atherosclerosis and further stenosis can result in thrombus. Not every one of those cases goes from the beginning of thrombus to complete occlusion. Some of them, and that's what I'll be sharing with you today, actually in the presence of pulsatile blood flow, that developing thrombus will embolize. And but most of them, or I should say most of them will embolize from a proximal stenosis, but some of them will actually go on to occlude. But the presence of occlusion doesn't mean that during the process of clotting that site, that there wasn't some clot that was washed downstream. So both stenosis and occlusion angiographically can be associated with distal embolization of thrombus. And generally, the site of lodging will be in the posterior tibial at the bifurcation into medial and lateral plantar branches. I'll show some examples from the SFA, iliac, and triple A stent graft, abdominal aortic aneurysm stent graft. Now, this is an example of a patient who had a sudden onset of severe pain in this middle digit 48 hours earlier. On palpation, he has an absent right popliteal pulse and an absent posterior tibial pulse. Angiographically, following 5 days of Lovenox and aspirin to give the systemic anticoagulation a trial to see if that would improve, his toe did not improve. And what we see on the angiogram is a severe stenosis, which responded normally to angiography and angioplasty, I should say. We see that the distal embolus is indeed at the bifurcation of the posterior tibial into medial and lateral plantar branches. We advanced a 2.3 French microcatheter into the thrombus and gave a very slowly, very concentrated bolus of 20 milligrams of glycoprotein 2B3 inhibitor, brand name ReoPro. And then we gave him 2 hours of RTPA at 1 milligram per hour. So after the bolus into the thrombus of abciximab and then 2 hours of infusion through the microcatheter, we've cleared his occlusion, and he now has a becoming normal appearance of his toe. His pain is gone, and we discharged him an hour after that. So it was the same day clearing of the thrombus that had embolized from that proximal stenosis. This is another patient, more proximal lesion. You can see that the patient has a left iliac stenosis, but high-grade stenosis on the right, which we suspect is a combination of underlying stenosis and thrombus. Distally, we see there's occlusion of the medial and lateral branches of the posterior tibial in the medial and lateral plantar branches. Overnight, we infused a low dose of TPA. Following a morning, we see that there is a marked change in that appearance, and we were presuming that the overlying thrombus has largely resolved. So we've gone ahead and placed a self-expanding stent, and then did a balloon angioplasty of the origin of the internal iliac. Looking downstream, we do the same thing we did earlier, which was the bolus of abciximab and then the infusion with the TPA. However, we noticed that whereas on the initial angiographic appearance, there was flow in the distal anterior tibial, there's not now. So looking proximally, we see that some of that material that we had treated was probably able to embolize with the stent implantation. So we now have a new occlusion of the anterior tibial artery. So we treated that in the same manner with a bolus of very concentrated abciximab into this occlusion, followed then by 2 hours of 1 milligram per hour of TPA, and that has reopened, and her toes now appear normal. She's happy, pain-free. A somewhat unusual case, but again more proximal, involving the equivalent of the aorta and proximal common iliac artery. We see that at the end of this stent graft, there's a marked stenosis. And on angiography, there's a somewhat unusual appearance, a little bit worrisome for either marked myointimal hyperplasia or thrombus. And downstream, we see that there is a occlusion of the, again, of the posterior tibial artery. So we treated that with the same treatment of the abciximab bolus into this area, and then TPA for 2 hours at 1 milligram per hour. And following that, there was very little change. So we assumed that what we were dealing with was primarily myointimal hyperplasia, put in a self-expanding stent, then brought the 2 French microcatheter down, put a bolus of abciximab into both limbs of the 10 milligrams each, into the 2 limbs at that bifurcation, posterior tibial, into the medial and lateral plantar branches, and that cleared that occlusion. So the results were that we were able to clear all the stenoses and the thrombotic occlusions, which meant clearing all of the distal emboli, and no bleeding, no recurrence of emboli because the proximal flow-limiting lesion had been addressed. No one went on to amputation, and there was prompt clearing of breast pain. So the takeaway message: if you have a blue toe involving only one limb and no pulse, think of clot. Look for a proximal obstruction, either stenosis, which would be more common than occlusion, and a distal embolus, usually due to the proximal stenosis embolize while attempting to go on to complete thrombosis. But sometimes it will be a complete occlusion because the thrombotic process had been able to complete itself, but during the process of clotting, some thrombus went downstream. Lysis will clear all the clot, and you can do it quite quickly because these are acute or subacute. What we have found is the quickest way is to lace with ReaPro or abciximab, and then a higher than we usually use dose of TPA for a couple of hours. Then treat the proximal obstructive lesion, treat with care, because as you saw in one of our patients, there was still some thrombus there that had been a large amount, probably of thrombus to begin with. And so that can cause further embolization. However, as you've seen, at least in our small series, that embolization can be cleared as well. So this is a year follow-up on that first patient. This was actually the toe that had been blue. You can see there's no skin loss whatsoever. And if anything, it's a bit hyperemic in this single image. So he had remained pain-free and had not had a recurrence of claudication. So thank you very much. It's been a pleasure to share this small but I think significant experience with you. And again, I thank Dr. Walker for enabling me to participate.